Thank you for your invitation. It is my pleasure to participate today. During this presentation, I will provide a definition of colorectal endometriosis. I will discuss the reason why ultrasound should be the primary diagnostic technique in patients with suspicion of colorectal endometriosis. I will describe the features and the variant of colorectal endometriosis on ultrasound. And finally, I will provide some information on the performance of ultrasound in diagnosing rectosigmoid endometriosis. Colorectal endometriosis must be defined as endometriosis infiltrating at least the muscularis propria of the rectosigmoid. Serosal lesion should be considered superficial endometriosis and not bowel endometriosis. Clinically, colorectal endometriosis involves the anterior rectum, the rectosigmoid junction, and/or the sigmoid colon. From an histological point of view, this disease, as I said, is characterized by the presence of endometriotic gland and stroma within the muscularis propria of the rectosigmoid. This causes a hyperplasia of the smooth muscle, but also an extensive fibrosis. In this picture, you can see a rectal nodule that was stained with a Mason trichrome technique, which demonstrated the fibrosis in blue and the smooth muscle in red. These histological characteristics cause a thickening of the intestinal wall and a narrowing of the bowel lumen. Ultrasound is particularly useful for the diagnosis of colorectal endometriosis because it is non-invasive, it is easily available for the gynecologist, usually well tolerated by the patient, it is not expensive, does not require the use of contrast medium or the use of radiation, and it is also a dynamic exam which allows to establish the presence of adhesions. Concerning the technique, obviously, it is performed by transvaginal ultrasonography. The probe must be placed in the posterior vaginal fornix, and it is well accepted that bowel preparation is not required before performing transvaginal ultrasonography for diagnosing rectosigmoid endometriosis. The use of transvaginal ultrasonography for the diagnosis of rectosigmoid endometriosis was standardized in the 2016 IDEA consensus, which reported the description of the assessment of deep endometriosis and included, obviously, the assessment of the rectosigmoid. On transvaginal ultrasonography, colorectal endometriosis appears as a thickening of the hypoechoic muscularis propria or as hypoechoic nodule with or without hyperechoic foci. The lesion in some cases have a thinner section or tail, which is present on one end, and this characteristics is named the comet sign. The typical appearance of the muscularis propria of the bowel is replaced by abnormal tissue with retraction and adhesions, and these result in the so-called Indian address or muzzle antler sign. The size of the lesion is extremely variable, and the morphological characteristics of the lesion is also variable. and they must be described according to the 2016 IDEA consensus. Here you can see the typical hypoechoic appearance of rectal endometriotic nodules. In this case, the nodule is located in the low rectum. You can see the uterine cervix on the top. And in this case, you can see that the nodule has some spikes that are directed toward the intestinal lumen, and the spikes are also present in this case, and these spikes typically are suggestive of the presence of extensive adhesion. In other cases, the nodule has a linear contour, as you in this image, and on one side, you can see that there is a progressive narrowing of the nodule that is indicated by the arrow, that is the so-called comet sign. And again, in this picture, you can see another nodule which has the progressive nodule, the progressive narrowing that is named comet sign. Here you can see an extensive nodule. The largest diameter of this nodule is approximately 5 centimeters, which infiltrate the intestinal muscularis propria. If we consider the IDEA consensus, we must be aware that there are 6 different morphological appearances of colorectal endometriotic nodules, and therefore I will try to provide a brief description of these 6 different cases. The first case is a nodule which has a regular outline, and there are no spikes, as you can see in the longitudinal and the transverse section. Here you can see the nodule which has the comet sign. On the right, you can see that there is a progressive narrowing of the nodule. Here you can see a nodule which has several spikes towards the bowel lumen. This is called Indian headdress or muzzle antler sign. Here you can see a nodule which has a prominent spike toward the bowel lumen, but it has also a progressive narrowing like a tail. Therefore, it has both the Indian headdress and the comet sign. And here you can see a nodule with a prominent spike toward the intestinal lumen and extrinsic reaction. There are visible mucosal folds, which is known as pulling sleeve sign. And the sliding sign, obviously, in this case, is expected to be negative. And finally, we have a deep endometriotic nodule with a extrinsic reaction pulling sleeve sign. The sliding sign is expected to be negative. On ultrasound, the bowel is adherent to the ovary, and there is an hypoechogenic area between the bowel loops and the ovary, which correspond to endometriotic tissue, but this nodule does not infiltrate the bowel wall. It is simply located between the bowel and the ovary. Concerning the vascularization, intestinal nodules are typically poorly vascularized, as you can see in this image, in this other case, or in this video. It is important always to assess the vascularization of the nodule. The absence of relevant vascularization further support the diagnosis of the endometriotic nature of the nodule. When we have a nodule, we must assess the depth of infiltration of endometriosis in the intestinal wall. The normal rectal wall can be visualized on transvaginal ultrasonography. In fact, the anterior rectal serosa is seen as a thin hyperechoic line. The muscularis propria is hypoechoic. The submucosa is hyperechogenic, and the mucosa is hypoechoic. In this case, you can see a nodule that infiltrated the muscularis propria of the rectum. However, the submucosa, which is hyperechogenic, is not infiltrated. When we identify a colorectal nodule, we must assess if it is an isolated lesion or if we have a multifocal or multicentric disease. It is important to define these two terms. Multifocal lesions are multiple lesions which affect the same bowel segment, while multicentric lesions are multiple lesions which affect several bowel segments, such as the small bowel, the large bowel, the cecum, the ileocecal junction, or the appendix. If we want to make the diagnosis of multicentric lesion, transvaginal ultrasonography must be combined with other imaging techniques such as MRI, computer tomography, colonoscopy, or multidetector tomography enteroclysis. Here we have an image obtained by multidetector tomography enema, and we can identify an ileal nodule that cannot be detected by transvaginal ultrasonography. And again, here we have a nodule on the ileum that was detected on multidetector computerized tomography enema. Obviously, we cannot expect to diagnose ileal lesion by transvaginal ultrasonography. When we identify a nodule, we must make a measurement of its diameter, and in particular, we must make the measurement in 3 orthogonal planes, as shown by the idea consensus in this slide. And also, we must assess at which level the nodules is located. The idea group identified 4 different locations of rectosigmoid nodule. The nodules that are located in the lower rectum, which is the retroperitoneal part of the rectum. Nodules located in the upper rectum, which is the part of the rectum that is visible at laparoscopy. Nodules located in the rectosigmoid junction, and finally nodules located in the anterior sigmoid. How we define the different location of this nodule? Deep nodule located below the level of the insertion of the uterosacral ligament on the uterine cervix are defined as low anterior rectal lesion. Lesions that are located above this level are denoted as upper anterior rectal lesion. Lesions that are located at the level of the uterine fundus are named rectosigmoid junction lesion. And finally, lesions that are located above the level of the uterine fundus are named anterior sigmoid deep endometriotic lesion. When we identify a rectosigmoid nodule, we must also assess whether there is an infiltration of, whether there is the presence of adhesion in the pouch of Douglas by using the sliding sign. And also we must try to estimate the distance between the lower margin of the lower lesion and the anal verge. This measurement can be performed by using 2 different methods depending on the location of the lesion. For the nodules that are located approximately at the level of the rectovaginal septum, the lower part of the nodule must be identified by transvaginal ultrasonography. An index finger is placed on the transvaginal probe at the level of the anal verge, and then the probe is withdrawn, and the distance from the probe tip to the index finger is then measured using a ruler, which provides the distance between the lower part of the nodule and the anal verge. In contrast, if we have lesions that are located above the rectovaginal septum, the distance between the lesion lower edge and the posterior cervix lower lip is measured on a frozen image. In addition, a distance from the lower lip of the posterior cervix to the anal verge is measured as performed in case of nodule located at the level of the rectovaginal septum. And then the distance is calculated by adding the two measurements. Concerning the performance of transvaginal ultrasonography in the diagnosis of rectosigmoid endometriosis, we can definitely state that the accuracy is good. This is a systematic review that was published by Professor Stefano Guerriero, which demonstrated, including 19 studies and over 2,000 patients, that TVS has a sensitivity of 91% and a specificity of 97% in the diagnosis of rectosigmoid endometriosis. A particular way to perform the scan is to add water contrast to the rectum. This is a technique that was developed in my institution several years ago. I have to admit that if the sonographer is experienced, the technique does not improve the performance of transvaginal ultrasonography in the diagnosis of rectosigmoid endometriosis. However, at the beginning of your experience, I believe it may help. But this technique may also be useful to estimate the degree of stenosis of the intestinal lumen created by the intestinal nodule. The degree of stenosis can simply be estimated on a 2D image approximately. And here you can see a video that gives you the idea of the stenosis caused by a rectal nodule, but also by using the 3D scan. This is a normal bowel that was filled with a saline solution, and then we did a 3D scan. But obviously, it is also possible to do this type of scan in case of intestinal nodule, and obviously this allows to estimate the degree of stenosis both in an image or in a volume. In conclusion, transvaginal ultrasonography must be the first-line investigation in patients with suspicion of colorectal endometriosis. It allows to estimate the presence of colorectal endometriosis, but also to assess the characteristics of the nodule. However, it does not allow to diagnose a lesion located above the sigmoid, and therefore it does not allow to establish the presence of multicentric disease. I want to thank you for your attention and to thank the organizer for their invitation.